Hello, good morning. Welcome everyone. And please keep joining. We are starting our session. So this is our fast track session from the 2019 paper. And we'll try to do 30 MCQs. And hopefully if you guys are joining, and we will be doing it as interactive as possible. I'll share the links in all Telegram groups, and you can find the link. You can come by yourself, bring your friends. So this is our first MCQ of the day. Here it is 22 years old male who is admitted with the episodes of paroxysmal supraventricular tachycardia, which is required cardioversion after the collapse at local nightclub. This is the second occasion that he has suffered palpitation over the past 6 months. He does not drink coffee and does not use illicit drugs. His blood pressure is 110/70 post cardioversion. His pulse rate is 85 beats per minute, regular. Chest is clear, and his body index is 22 kilogram per meter square. And in the investigation, hemoglobin of 13, WBC 7, platelets 203, so full blood count is normal, sodium and potassiums are normal, creatinine is 85, which is also normal, and in the ECG there's a sinus rhythm with shortened PR interval with delta wave, so apparently looks like SVT with WPW syndrome. The patient admitted with the episode of SVT and collapse, and now he's vitally stable. So let's see what's the question. Which of the following is the most appropriate long-term intervention? In a young male with history of presentation as SVT, ECG is suggestive of WPW syndrome. So what would be the most appropriate long-term intervention? Any clue, any answer? Either you can unmute yourself and tell me the answer, or you can type.
E. Radiofrequency ablation.
Okay, radio frequency ablation. And why not amiodarone or atenolol or digoxin and flecainide? If I say that's correct, so let me explain.
Because of the long-term intervention.
Long-term intervention. Okay. Even if I say that acutely, if you have to treat this patient, what would be the option? So all the AV conduction blocking medication, if either patient is in atrial fibrillation or there is a chance that he can go into atrial fibrillation, if we block the normal conduction pathway, because we know that this WPW syndrome, it is an accessory pathway. So what will happen that the conduction via the accessory pathway will go in the same frequency and speed, and which can lead to ventricular fibrillation. So you can remove both of atenolol and digoxin in that way. Flecainide we could use, but we must know that if the patient has been given the history of ischemic structural heart disease, that is one of the contraindication, and amiodarone itself, it is the cause of QT prolongation, which itself increases the risk of arrhythmias. And as you said, radiofrequency ablation is the most appropriate answer here. And other than that, regarding amiodarone, in the long term, it has got its own side effect profile, including thyroid dysfunction, photosensitivity, lung fibrosis, and arrhythmia, as I mentioned. So, so most appropriate intervention, as we said, it is a radiofrequency ablation to remove the focus of abnormal accessory pathway. Then an 18 years old male is admitted to the emergency department with right upper quadrant abdominal pain, nausea, vomiting. He tells you he's chronically anemic and has a problem with his red blood cells that runs in the family, and the episode of abdominal pain have increased over the past few months. He looks pale, pyrexial with the temperature of 37.9. His blood pressure is 105 by 72. Abdomen palpation confirms tenderness in right upper quadrant, and you also note that he has splenomegaly, and his investigations include full blood count. There is uh, low hemoglobin of 9.8 with spherocyte sites identified on film. So it looks like it is a scenario of spherocytosis. WBC is high 15.2. Platelet maybe an element of infection ongoing at that time. Platelets 201, electrolytes sodium 144, potassium 4.9, creatinine 1 2, and CRP is 220. So apparently the scenario of hereditary spherocytosis with an element of infection, and ALT is 89, which is also on upper side, alkaline phosphatase 322, and bilirubin of 22. It looks like this is an obstructive picture in the LFTs. And then, which of the following most likely cause of his right upper quadrant pain? Patient of hereditary spherocytosis came with right-sided abdominal pain and cholestatic liver function test picture. What is the diagnosis? Yes, perhaps. Please, if you have the answer. Any clue?
No, I don't know this
What?
answer.
So, is this a scenario of some infection like spread, any diarrhea or anything like hepatitis picture, or any infection which is in community and it's or in nursing home, nursing care, which are the common scenario like hepatitis A? Is it the scenario look like Gilbert syndrome, which we know it is a condition in which the general condition of the patient remain normal, and in the time of stresses or starvation, bilirubin can rise. Is it a cholestatic picture which can present in Epstein-Barr virus? So it's no, it can cause hepatitis, okay, but it's not that case. It doesn't look like a picture of Pitt-Carey syndrome, in which we know it is a thrombotic state, and where we can have other features of pancytopenia, but it doesn't go. But in the patient of hereditary spherocytosis who can have hemolysis, and due to which he can have this cholestatic picture, and having said that he's having stone stones, so these patients have tendency to go into cystitis and ascending cholangitis. So that's why this is the scenario, and that for prevention and the treatment, as we know, for reducing the chances of hemolysis with the large spleen, splenectomy is one of the options. Pitt-Carey syndrome, as I said, this is a condition of thrombophilia where there's a maybe right upper quadrant pain, and there may be portal hypertension and ascites, but the features here they are of infection with cholestatic blood picture. So the answer is cholecystitis. And there won't be a cholestatic type of picture in Epstein-Barr virus. As we said, it's not a picture of Gilbert syndrome. Hepatitis, usually the scenarios they are coming in the community setting, in a setting where in the nursing home or maybe in the hospital, and the features usually They can present with diarrhea and other symptoms, but the picture is not always cholestatic. But so this is the rationale. The 18 years old woman who is sitting her end of a school exam and reviewed in first seizure clinic. She suffered generalized tonic-clonic seizures 2 to 3 weeks earlier while walking to school. You understand from the patient and her mother that she has suffered from increasing clumsiness affecting the upper limb over the past few months, particularly in the morning when she seems to suffer from involuntary jerking. They feel that the jerky lymph movement are worse if she is sleep deprived. She has normal neurological symptoms. She is otherwise well, and although she has struggled with the weight gain, neurological examination in the clinic is entirely normal, and electrocardiogram is encephalogram recorded the previous week shows 4 to 6 hertz bilateral polyspike and slow wave discharges with the frontal predominance. From which of the following therapies is the most likely to benefit? So this is a scenario of epilepsy which doesn't look like channelize in view that they have given a particular part of the body, the limbs where there's more, and there is a clue in EEG picture, the type of epilepsy, then the treatment. You have to decide what would be the appropriate treatment in this condition. Is it carbamazepine, levetiracetam, phenytoin, sodium valproate, and vigabatrin. First of all, as I said, if you understand the diagnosis, then the answer is straightforward. So, which medication would be appropriate here?
Sodium valproate.
Sodium valproate. Okay, so this is what type of epilepsy is here?
Myoclonic.
Myoclonic epilepsy. That's fine. Good. So yes, sodium valproate also can be used, but if I say that she is a female, you should choose any medication who has the less risk in terms of
Levetiracetam.
yes. So yes, levetiracetam. So that's the rationale. Myoclonic epilepsy picture presentation and EEG with polyspike and slow wave discharge is typical for myoclonic epilepsy. Carbamazepine, rather improving it can precipitate. Sodium valproate, we will not use it here. Phenytoin also has got the side effects, right? That's why it's not recommended. So the medication which we can use in myoclonic epilepsy, they are sodium valproate, levetiracetam, and lamortigine, and that's why your answer is correct. And so intervention of the choice due to in myoclonic epilepsy it present in the children and sometime in the early adult age it's improved by itself, and and as we said that the side effect of sodium valproate is also not there with levetiracetam. Carbamazepine is not an appropriate option because uh, it, it it is a treatment in the complex and partial seizure, but not here. Phenytoin also exacerbate like carbamazepine, as I said earlier, and the long-term side effects profile is inappropriate for an 18 years old female who can be or who can think of being pregnant in the future. So these are the contraindication of the other medication which we talk about. And and again with the vigabatrin, we have same similar side effect profile, including weight gain, psychiatric disturbance, optic atrophy. So that's why most appropriate option is levetiracetam. A 20 years old student come to the infectious disease clinic a few weeks after returning from holiday to India. He has been suffering from night sweats 3 to 4 times per week, vague right upper quadrant pains and diarrhea, which is often blood-stained and contains mucus. He has lost some 4 kg in weight. Examination reveals blood pressure of 102 by 80, pulse of 70 beats per minute and regular. His body mass index is 21.5. There is a mild abdominal distension and pain in the right upper quadrant on palpation. Investigations include hemoglobin of 10.9, WBC, there is a leukocytosis is 14.5, platelets 203, sodium 142, potassium 3.5, creatinine 102, and ALT is 104, alkaline phosphatase is 289, bilirubin is 12, albumin is 32. So this is a kind of scenario which I say that which we should read from the end of the scenario rather than losing ourselves in between the scenario. So what is the most likely diagnosis? I will explain the scenario again. Either it is a E. coli infection, Entomeba histolytica, Giardia lamblia infection, Salmonella typhi infection, or Shigella sonnei infection. So these are the options, and let me explain the scenario. So this is the scenario of 21 years old male who is coming from India. Now he has got diarrhea, right upper quadrant pain, and bloody diarrhea. He has got weight loss. There's mild distension of abdomen and right upper quadrant pain. So, what type of infection can cause all these features? Someone who is coming from Asian countries, now features of tenderness on the right side of the abdomen. Think in terms of infection which can affect the right hypochondrium. Can it affect to the liver? So these are the options. E. coli,
E.
Entomeba,
coli. E. coli.
E. coli, Entomeba histolytica, Giardia lamblia, Salmonella typhi, and Shigella sonnei. So with regards to this scenario, E. coli, we say it is a commonest cause of traveler's diarrhea. Does it cause anything related to the liver like abscess? Giardia lamblia, we know it is a type of infection and it can be infection in the travelers and a type of a chronic infection, but the symptom is only diarrhea, may not be associated with the blood. Salmonella typhi is a type of infection. Also, it can be associated with the bloody diarrhea. It has got its own features of relative bradycardia and others. Shigella sonnei infection. It's also an infection with dysentery, but and amoeba histolytica, we know that is an infection which can make the abscess in the liver and liver function test. So this is the most appropriate diagnosis. As I said, E. coli also it's a short-lived type of infection and it improves in few days. If we talk about the commonest cause of the traveler's diarrhea, then it is E. coli, but the infection which can affect the liver, it's Enterobiba histolytica. Treatment is metronidazole and with the course of duloxetine, which can improve the cyst. Giardia lamblia, it is type of symptoms which are look like IBS. Salmonella typhi, as I said, it is a diarrheal infection which can be associated with the blood, and the other features of Salmonella, Shigella present like a dysentery. So that's why Entomeba histolytica is the correct answer. Then we have 37 years old woman who has a primary pulmonary hypertension come to the clinic for review. Her symptoms are stable. She is on bosentan and amlodipine, and she is able to walk up to half mile on the flat without stopping. She tells you that she is 8 weeks pregnant and plans to continue the pregnancy. Her blood pressure is 135 by 84. Pulse is 72 beats per minute. Her chest is clear and there is minor pitting edema affecting both ankles. Routine blood tests are unremarkable. Which of the following is the most appropriate course? Primary pulmonary hypertension in a female who is pregnant, stable at the moment with the medication given bosentan and amlodipine. What would be the appropriate course? Whether they should we should advise to terminate the pregnancy, stop the bosentan and continue amlodipine, stop bosentan and amlodipine both, aid sildenafil or switch Busenton for sildenafil. Yes, any clue, any answer of it? Still, I'm waiting for the people who can join. Okay, so first of all, first option, termination of pregnancy. Shall we say to someone who is stable on the treatment, her pulmonary hypertension is not troublesome, which is sometimes an indication for termination of the pregnancy? Stop Basenton and continue amlodipine. We know that pulmonary hypertension is something which should not and has got a risk to the um, maternal risk. So that's why we should not think of discontinuing the medication. Stop both the medication. That's also not an appropriate option. And either we need to add another medication with that one, so that's also not an appropriate option because patient is already comfortable with these medication, or we should switch Basenton to sildenafil. So let's see. This is the answer, and why we should switch Bosentan to sulfenadil, because it has been found as having fetal toxicity in rats, and it is an endothelin receptor antagonist, and it can lead to malformation of head, mouth, face, and large blood vessels. So that's why they should be discontinued, but they should be switched to phosphodiesterase inhibitor, and because they are not teratogenic, and rather than as we said about other medication, that we are not saying to terminate the pregnancy, we are not saying to discontinue one of the medication because patient is stable, and rather than leaving the patient with pulmonary hypertension with the maternal risk, they are all the inappropriate options. Then 25 years old woman with a type 1 diabetes come to the diabetes clinic for review. She is 20 weeks pregnant and has been diagnosed with background diabetic retinopathy, but now present with blurred vision affecting her left eye and a documented reduction in the visual acuity. Her blood pressure is 110 by 80, pulse is 70 beats per minute and regular. Fundoscopy reveals macular edema affecting the left eye with HbA1c is 6.2 and she is using insulin pump. Which of the following is the most appropriate intervention? 25 years old type 1 diabetic female patient with the previous history of diabetic retinopathy, currently having macular edema. What is the appropriate intervention? Shall we reduce the insulin dose? Is the tight control of HbA1c is causing this? Shall we do a focal photocoagulation, or we should give intraventral ranelizumab, which is vascular endothelial growth factor inhibitor? Shall we do a pan-retinal photocoagulation, or we should start ramipril in her while she is pregnant? Yes, any clue? Okay, so the answer is focal photocoagulation. Decreasing the insulin dose will not make any difference. HbA1c in a diabetic patient, even though in the pregnancy the control is all right. Intraventral ranelizumab is not indicated here. Pan-retinal photocoagulation is indicated when there is a new vascularization. Ramipril is a teratogenic during the pregnancy. The answer here is focal photocoagulation. Let's see that, as we said, intensified glucose control in pregnancy, and patient is having site-threatening edema. It's not appropriate here. And decreasing the insulin dose means, like, we know that optimizing the diabetics control in pregnancy is much important to prevent the complication associated with the hyperglycemia, like macrosomia and other complications. And then intraventral ranibizumab, as we said, it is a VEGF inhibitor. It is uh, it is used for intravitreal treatment of macular edema, but we should not use this one. There are no data regarding them. They are used in pregnancy. Pan-retinal photocoagulation, it is indicated, as I said, in proliferative retinopathy, and but the scenario with only macular edema here in pregnancy, most appropriate option is focal photocoagulation. And as we said, uh, obviously ramipril, ACE inhibitor or ARB, they reduce the progression of microvascular complication, but in a patient with pregnancy, they are both teratogenic, so that's why that's not appropriate option. 27 years old woman is brought to the emergency department by her husband. He is concerned that he has become increasingly confused and drowsy over the past week, with poor short-term memory and deterioration in her walking with tendency to trip over. She was previously well and takes no regular medication. She returned from business trip to Tokyo some 3 weeks ago. Examination reveals pyrexia of 38.2, and her blood pressure is 105 by 80. She has an ataxic gait. You can demonstrate both expressive dysphagia and short-term memory loss. 27 years old, acutely confused for few days, and features of dysphagia, short-term memory loss. Patient is pyrexic, and with regards to the investigation, hemoglobin is 12.8, WBC 8.1, platelets 209, sodium and potassium are normal, as well as creatine, glucose is 6.1. MRI shows increased signal intensity in right temporal lobe and insular cortex. Cerebrospinal fluid protein is raised, which is 1.2, and CSF shows lymphocytosis. Here, MRI picture, CSF picture, everything is important in a patient acutely confused, having some features related to the brain damage. Which of the following is the most likely diagnosis? Involvement of the temporal lobe, lymphocytes in lumbar puncture, young female, history of recent travel, coming with confusion. What is the most appropriate answer? The temporal lobe involvement and lymphocytosis. These are the clue I will say here.
A. Herpes simplex encephalitis.
Yes. And what's the rationale of it? Yes, as I said, there is a temporal lobe involvement which is common there, and it is lymphocytosis, and the protein is raised protein in viral infection. It can be normal or it can be raised. Mycoplasma meningitis, we can have the other feature associated with mycoplasma, like also the tympanic membrane, uh, inflammation, problem with the hearing, subacute sclerosing panencephalitis. It occurs as a complication of the measles in the past, and after 10 to 15 years, we can have this subacute sclerosing panencephalitis. Tuberculosis can be present with this type of picture, and but the MRI picture patient can have lymphocytosis, but protein will not be raised in case of tuberculous meningitis and what I will say, any leukocytic or bacterial meningitis. So as we said, MRI changes and short-term memory loss, and so PCR is indicated to confirm the diagnosis. So confirmatory diagnosis of herpes simplex virus encephalitis is PCR. Treatment is IV acyclovir. If the treatment is started early, prognosis is good. If it delayed, it's worse. Japanese encephalitis is in Japanese encephalitis, the lesion are in thalamus, substantia nigra, basal ganglia, and cerebral cortex, cerebellum, brainstem, and white matter. The incubation period of Japanese encephalitis is 5 to 15 days, and which also doesn't fit with the scenario here. And then Mycoplasma meningitis, as I said, it can present with the respiratory issues like pneumonia, ear infection, and inflammation of the tympanic membrane, and also the CNS infection can occur. It can lead to encephalitis or a septic meningitis. With regards to subacute sclerosing pancreatitis, as I said, that this happens on the background of the measles. Tuberculous meningitis, there should be a more history or traveling history specific to the endemic countries when the scenarios are coming with the tuberculosis. Then 42 years old male come to the clinic for review. He takes allopurinol 300 milligram per day for the treatment of the gout. Yet he has still had two acute attacks of gout over the past 4 months. Despite also taking naproxen, his only other medication is ramipril for hypertension. His blood pressure is 132 by 82, pulse 72 and regular. Body mass index is 26. So this is a scenario 42 years old who is already on allopurinol but still having recurrent episode, taking naproxen. Vitally he is stable. In the investigation, uric acid is still 9.36. Urea electrolytes and blood picture is normal. So what is the question? Which of the following is most appropriate intervention? So what would be the next appropriate treatment to control or manage his uric acid, because patient is still having episodes of recurrent gout while on allopurinol? So what would be the next step to treat his recurrent or prevent his recurrent gout with hyperuricemia? Okay, I can't see any answers in the chat box as well as here. So the answer is benzobromarone. Fixed buxrotate can be used in a patient who are intolerant. It is also similar to allopurinol or can be added sometime with the allopurinol, but allopurinol is not working here. Thus, Buricase is used in hematological malignancy. It increases the excretion of the uric acid with an increased breakdown. Bendoflumetholide is a thiazide diuretic which increase the hyperuricemia. Colchicine is used as a, in the case of acute presentation to prevent or improve the acute episode and pain in the patient who cannot have NSAIDs. And so benzobromozoin is an inhibitor of the uric acid transport 1, which is a non-competitive xanthine oxidase inhibitor. It reduces the uric acid on top of allopurinol or febuxostate, and it can be used in United Kingdom on a named patient basis. This is because of its withdrawn from general cell during 1970 due to hepatotoxicity. In the event it is started in the patient, regular monitoring of the liver function is needed. So due to this side effect, it's avoided. But in case when the patients are improving, not improving with cefpaxate and allopurinol, then this is an indication. We talk about the thyroid diuretic, it increases the risk of hyperuricemia. Colchicine is the treatment of acute gout for the patient who are intolerant, either not improving or cannot take the NSAID. Fuxabaxis is the same uh, alternative to allopurinol. Mrcp, as we said, is a recombinant urine oxidase. It is used in the prevention therapy of uremic nephropathy in the patient with hematological malignancy who are undergoing induction chemotherapy where white cell deaths can lead to precipitous increase in serum urate. So the next scenario is 23 years old woman who is referred to the dermatology clinic with intensely itchy vesicular rash that has affected her buttocks, backs, thigh, and extensor surfaces of her arms. She tells you she has lost weight and feels tired all the time, intermittent diarrhea, abdominal bloating. Although her general practitioner has told her this is due to down to the irritable bowel syndrome. On examination, you can see extensive vesicular rash with obvious scratch marks. She is slim with a body mass index of 21. A 23 years old woman with history of diarrhea, weight loss, and having the vesicular rash on buttock, backs, and thigh. And investigation, she is anemic with hemoglobin of 9. WBC and platelets are normal. Sodium, potassium, and electrolyte and creatinine, they are also normal. Diarrhea with vesicular painful rash on extensor area of the limbs and buttocks. So what is the most likely diagnosis of our presentation?
AC leak disease.
Yes, this is most obvious as we talk about. We have done previous scenarios. Crohn's disease, it can have some mucosal involvement in terms of abscess ulcers, but the skin lesion associated with this one are others like pyoderma, gangrenosum, but not this one. Hypothyroidism, it can have a skin lesion, but not presentation like this. The anemia, if we talk about, it would be macrocytic anemia there, as well as the, we know the rash which are associated with that one. The history of hair loss, weight gain, bradycardia, and erythema acne is the type of skin lesion which can present with hypothyroidism. Sarcoidosis, we know it's a granulomatous uh, disease. And in this one, we have erythema nodosum, which is present in the on the shin, and as well as type 1 diabetes, we have the rash granuloma annulus, which is also one of the differentiating lesion on the shin. So as we said, celiac disease, and the lesion most likely would be dermatitis herpetiformis. And as we talk about the erythema nodosum, the lesion which can be present either F skin related to skin and mucous membrane, including F ulcer, erythema nodosum, and pyoderma gangrenosum. Hypothyroidism is associated with hair loss, duffy feel of the skin with vesicular rash, not with the vesicular rash. Sorry. So sarcoidosis, as we said, like inflammatory bowel disease. It also has erythema nodosum. Type 1 diabetes is associated with necrobiosis lipodisa, which is a red brown plaque-like lesion which occurs on the lower limb and gradually enlarges with the formation of the yellow atrophied skin at the base. Then you review a 48 years old male with suspected Cushing syndrome and plan to arrange cortisol sampling to contribute the diagnostic workup. When are that cortisol level expected to be at their lowest in the normal individual? So what time of the day the cortisol level would be at the lowest level? If we know what time they start to increase, then we can understand that what would be the time of
At
the
night.
at
At
night.
night.
Yeah, because in the morning time, early morning, they start increasing, and in the condition when they are not optimally raised, this is a condition of cortisol deficiency, which is Addison disease, for which we do synthetic test. And the other times, like if it is at 12 o'clock in the midday or 1700 hours in the day, these are the time of activity, and at that time they are not the right time to monitor them, and at that time the cortisol levels would be high. So that's why. But in case of the people, if the scenarios are given, the people who are working at the night time, in that case their level may be raised because their cycle of this cortisol secretion would have rise into the daytime. That's why it's well said that the people who are working in the night time, they are having agitation in the evening time, which is their time of secretion of these fight and flight hormones. So this is the rationale, as we said, that they lower down at the midnight and then start peaking in the early morning. And as I told about synectin, if they are how we do synectin test, we know after giving an injection of cosintropin, we measure either rise of more than 200, or after 30 minutes it become more than 600, it is normal. If it doesn't, then it means that patient is having Addison disease. This is which is the deficiency of hypoadrenalism state. And the time, as we said, that both the other times when the people are highly active, they are not the time when we monitor it. And the investigation which are specific, which we do for Cushing syndrome, we said overnight dexamethasone suppression test, as well as urinary free cortisol. A 23 years old woman is referred to the gastroenterology clinic for investigation of anemia. She complains of increasing tiredness over the past 6 months. She has suffered from intermittent bloating and diarrhea over the past 3 years. She has normal menstrual cycle regulated by the combined oral contraceptive pills. Physical examination is unremarkable. Her body mass index is 21. investigations include, so 23 years old female having GIT symptoms. Uh, she is using OCP to regulate menstrual cycle. BMI is nearly, I would say, normal or not very high or low normal. She is anemic. MCV is 77, which is also going towards a nearly microcytic picture. WBC is normal, platelets are normal. Urea electrolytes and creatinines are normal. Alkaline phosphatase is 189. Calcium is also low, which is 2.1. Albumin is 40. Female, diarrhea, nutritional deficiency, uh, ab- abnormal menstruation controlled with combined. What would be the next investigation to confirm the diagnosis? What would be the appropriate next investigation basically? But I would say to confirm the diagnosis. Any clue? GI symptom, nutritional deficiency, weakness, uh, poor menstrual cycles controlled with OCPs. What's the diagnosis? What you will investigate? Is it the symptoms are of lower GI pathology like colitis? Should we do colonoscopy? Any upper GI symptoms? Abdominal pain, epigastric pain, and then with iron deficiency, anemia, shall we do endoscopy? But we have other nutritional deficiencies as well. Is it haptoglobin? Is a state of hemolysis which can tell us from the haptoglobin. Do we need to do a hysteroscopy? Is the patient is having anemia or bulky uterus, something given in the history, or it is a celiac disease which is associated with the nutritional deficiency? So that's the correct answer. And as I explained, the other options, so NTTTG would be the investigation and gold standard choice of investigation to confirm celiac disease with all of these features. And then we have already talked about the explanation of all the wrong answers. So 42 years old bank worker is admitted to the emergency department with extreme agitation and central crushing chest pain. He admitted to taking cocaine and regular user each day. He also smokes 20 cigarettes per day. His blood pressure is 155 by 95. His pulse is 105 beat per minute and regular. He has bilateral basal crackles on auscultation of the chest, which are consistent with mild cardiac failure. He has been given aspirin by the paramedics, and investigation include 42 years old male came with agitation, chest pain, smoker, and cocaine user, tachycardia, high like blood pressure, and then features of mild cardiac failure. Investigation full blood count including Hemoglobin WBC in platelets is normal. Urea, electrolytes, and creatinines are normal. Troponins are normal. There is ST elevation in chest leads from V1 to V4. And then, what is the most appropriate intervention for his chest pain? Cocaine user, smoker, chest pain, cardiac enzymes are normal, but there is ST elevation in anterior chest leads. What is the most appropriate intervention if we know the pathology or mechanism of this chest pain in this patient? So this is a scenario of coronary vessels vasospasm, which is because of his history of cocaine use. So in this condition, we use the medication which reduces the vasospasm like calcium channel blocker and the nitrates. Atenolol, it can precipitate the spasm more. Clopidogrel is not the treatment here because there is ST elevation. Cardiac enzymes are normal. It doesn't look like that patient has got any myocardial infarction. And as we know, we can load the aspirin and clopidogrel, and later on we can continue according to the insertion of stent for 2 years. For a period of 1 year, we give 12 antiplatelet. Diazepam is not the answer here. This is the pain. We know it is because of the vasospasm, which is due to the cocaine use. PCI is not indicated, doesn't look like apparently useful here. But anyways, if the cardiac enzymes are raised, vasospasm has persisted for a long time, it has causing the occluded myocardial infection, then this could have been an option. But in a scenario of a patient with a cocaine use where there is a vasospasm of the coronary vasculature, so the treatment is GTN or calcium channel blocker. Beta blocker, as I said, that there is a risk of unopposed alpha stimulation may actually worsen the coronary artery spasm and exacerbate the situation. So that is obvious. Beta blocker are actually contraindicated in this condition. And then if I talk about the clopidogrel, as I explained, that the patient doesn't look like the pain is related to the ischemia of the coronary arteries, rather vasospasm. PCI would have been an option when we think about the myocardial infarction. Then 28 years old woman is admitted from the obstetric clinic where she has attended a 20 weeks checkup. Over the past 2 weeks, she has felt increasingly short of breath, suffered from palpitation, particularly when tries to exercise. Diastolic murmur was noted at her booking with visit, but this was thought to be a non-significant. Her blood pressure is 110 by 80 and her pulse was 90 beats per minute. There is a mild diastolic murmur which is best heard with the patient is left lateral position, and there are crickles on both passes which are consistent with the cardiac failure. Routine bloods are unremarkable. Her general practitioner has started furosemide of 40 milligram with a little impact on her symptom. Which of the following is the intervention most likely to be successful? So, pregnant female patient with a diastolic murmur, likely mitral stenosis, atrial fibrillation, diuretics have been given. So, which intervention is likely to be successful in our condition? And we need to think that what would be appropriate in terms of her pregnancy state.
Ramipril.
So you said Ramiprim. So we said the patient is pregnant. Would it be appropriate to start any of the medication, including Valsartan or Ramiprim, which are teratogenic? So that is
Anti-weak. Okay.
this is absolutely not correct
Uh,
answer. Yeah. Then if I say remove both of them, then what would be the other option?
Bisoprolol.
Bisoprolol, you can think of heart rate is not that high. Bendroflumetazide is not needed. Patient is already on furosemide. And why not we should think of valvotomy, which can be done. That is not that invasive process. Only the contraindication would be if there is a thrombus or the calcification.
Okay, okay.
So this is the most appropriate option here. So as I said, cardiac failure, atrial fibrillation is likely caused with mitral stenosis. Limitation in pregnancy, we can give only long-acting nitrates and diuretics and control heart failure and beta blockers to control the ventricular rate. So that's why PMV is the most appropriate answer here. If the heart rate would have been significantly high and we are thinking that is causing it, so maybe then the rate control would have been an option. Bendochromatosis rate is not needed here. And the beta blocker, which are appropriate here, they should be something which have in pregnancy highly selective beta 1 antagonist and adrenal antagonist like metoprolol, they are preferred in the pregnancy. Rapiprazole and valsartan, as I talk about, they are contraindicated in pregnancy. And then you are investigating a family for increased susceptibility to both rheumatoid arthritis and type 1 diabetes mellitus. They are found to have B positive for major histocompatibility complexes class 2 antigen DRB1. Which of the following cells usually express MHC class 2 antigen?
B dendritic cell.
Dendritic cell. Let's see. Answer B. These are kind of MCQs everyone like at the moment we are doing, and obviously these recording will go in all the telegrams group whenever you are listening. These are the things like which are related to major histocompatibility complexes, tumor markers, and their enzymes. And then I would say side effects of the cancer medication. You have to remember these type of questions come again and again, and this one always if you keep practicing these MCQs you can remember them. There's no rocket science or the way that we can memorize them, but we always need to remember MHC class 2 antigen are expressed on antigen presenting cells. They are responsible for processing antigen and presenting them on their cell surface in a way that can be recognized by T lymphocytes. They are vital for the successful adaptive immune responses. Macrophages and B cells are other examples of antigen presenting cells. Cardiac myocytes, they are MHC class 1 antigen. Goblet cells, they are simple columnar epithelial cells which produce the gel forming mucin and so on. So the answer here is dendritic cells. Neurons are class 2 antigens which are seen in small subpopulation of the neurons. When they are expressed to interferon gamma, they are not usually expressed by neurons which may express class 1 antigen in response to viral infection. Then again, red blood cells, they either do not possess either MHC class 1 or 2. This is because mature red blood cells do not possess the nucleus. So next question, excuse me. So 29 years old woman is reviewed in sexually transmitted infection clinic. She has suffered left iliac fossa pain and pain on passing urine over the past few days. She is 20 weeks pregnant and has recently separated from her partner because of he has admitted to an extramarital affairs. a vulvovaginal swab sent for nucleic acid amplification testing, which is positive for chlamydia. Which of the following is most appropriate antibiotic? 20 weeks pregnant patient positive for chlamydia. So what antibiotic would be appropriate while she is in pregnancy?
Azithromycin.
Yeah, azithromycin should be more appropriate. It is also suitable in pregnancy. Erythromycin is also again a macrolide, but azithromycin would need only one dose. Erythromycin, you have to stick with the side effect of the macrolide. Ofloxacin is contraindicated and it causes the cartilage damage in the fetus. Trimethoprim again is not the treatment of chlamydia. Amoxicillin can be used if there is any contraindication or intolerance. In that case, we can use. So this was the explanation of this scenario. As I explained all the options. Then 18 years old male who comes to the renal clinic having been admitted with E. coli infection some 4 weeks earlier in ultrasound shows shrunken left kidney with evidence of scarring. His GP has noted borderline hypertension. On further questioning, it transpires patient will suffer from recurrent UTI in childhood. His blood pressure is 145 by 88, pulse is 75 and regular. His abdomen is soft and non-tender, and his body mass index is 22 kg per meter square. And investigation: 18 years old male, E. coli, UTI, ultrasound showed left kidney shrunken with a scarring, and he has got borderline hypertension, history of recurrent UTI in the past. His vitals are stable. His body mass index is in the normal range. Investigation: full blood count is normal. There is mild renal impairment. Electrolytes, although they are normal. Creatinine is 133. And we talk about that left kidney scarring, which may be associated with renal impairment. So, what would be the most appropriate next step? I would say, what would be the appropriate investigation to confirm the cause of scarring? What investigation would be appropriate here? It is long-term trimethoprim therapy, computed CT abdomen and pelvis with contrast. Are we concerning about the anatomy of the kidneys? Are we going to treat an infection while infection markers were given normal? We were told that he was treated for UTI, but we are not talking about the UTI. Is it radionucleotide cystogram which would be okay for this patient? Is it repeat urine microscopy and culture that is still we are concerned that patient is having UTI? Or it is mixed-urating cystourethrogram? Any clue, Maha? Any answer here?
CT abdomen and pelvis.
It will show the anatomy, but it will not tell you that what has happened which have caused the damage to the kidneys. It is micturating cystourethrogram, which will give you the diagnosis or can tell you about if patient is having still reflux, which might have been causing the urinary tract infection and again, and with the history of young age recurrent history of UTI. Radionucleotide cystogram is used for confirming these in children. Rest, long-term trimethoprim therapy. At the moment, we are not concerning about the UTI. Infection markers are okay. So why to go again to for that one? And CT, pelvis, and with contrast will give you the anatomy but will not give the cause. Okay, so just a quick break for 30 seconds, and then we will. So this is a scenario of 19 years old male who presented to the rheumatology clinic with progressively worsening lumbar spine pain, which has increased in the severity over past 4 months, and he has tried taking paracetamol, although there is no longer controlling his symptoms, and he has been diagnosed with bilateral plantar fasciitis. Clinical examination reveals bilateral tenderness over the sacroiliac joint and the limited forward and lateral flexion of the spine. In the investigation, his hemoglobin is 13.2, WBC 9.1, platelets 239. His CRP, I would say here, would be likely inflammatory, while WBC is normal. Is 65. His sodium is upper normal 145, potassium 4.5, creatinine is 100, and he has got sacroiliitis. It means that he is having ankylosing spondylitis. And then the question is, which of the following most appropriate intervention? So let me repeat it again. The scenario of ankylosing spondylitis, and patient CRP is 65 in the positive investigation. He has got sacroiliitis on the X-ray, and at the moment he is only taking a, I would say, a very weak analgesic, first line analgesic, which is paracetamol. So what should be the second option of treatment, or what would be the intervention as it said in the MCQ? Would we start him on golimumab? Does he need to start on another TNF inhibitor, infliximab? Do we need to start him on DMARD, which is methotrexate, or we need to increase or optimize his NSAID cover with naproxen, or we need to go to the prednisolone?
D naproxen.
Yes, T-naproxen, as we said, and we know that in ankylosing spondylitis, First of all, we try to optimize their NSAIDs, and as we know that naproxen is a strong NSAID, but if it doesn't work, then we should go to the 10 TNF alpha inhibitor, and the most common and the TNF inhibitor which are, you can say, agreed for ankylosing spondylitis. First of all, they are etanercept and adalimumab. Okay, and then always when we are starting on TNF inhibitor, we always need to check their tuberculosis because there is a risk of reactivation of the tuberculosis. Infliximab is not indicated in case of ankylosing spondylitis. Otherwise, it is indicated in rheumatoid arthritis as well as an inflammatory bowel diseases. Methotrexate is also indicated in rheumatoid arthritis and psoriatic arthritis. Prednisolone is not an indication at the moment before due to side effect profile and as the escalation protocol for ankylosing spondylitis. Okay, so question number 19. 32 years old woman is admitted to the acute medical ward suffering from pulmonary and renal vasculitis. She is found to be suffering from granulomatous with polyangiitis. A decision is made to commence her on intravenous cyclophosphamide and methylprednisolone. Which of the following correctly describe the primary mode of action of cyclophosphamide? So here the patient, the diagnosis of granulomatous polyangiitis, just what is the mechanism of action of cyclophosphamide? Sorry. Okay, so let's see the answer. No answer I have got. Bone marrow suppression. Is it inhibition of neutrophil migration? T cell modulation. It is VEGFR inhibitor, which is absolutely no. But T cell modulation is the mechanism of action of cyclophosphamide, and then it is metabolized into liver to active metabolite 4 hydroxy cyclophosphamide and aldophosphamide. These exert their effect on the cell which have low level of alcohol dehydrogenase, which includes some subtype of T lymphocytes, mainly CD4 positive lymphocytes, and the lesser extent to CD8 positive lymphocytes. Bone marrow suppression have relatively high of alcohol dehydrogenase activity, meaning that unselected downregulation of the bone marrow activity is not usually seen. Relatively high level of cyclophosphamide can therefore be used in induction of immunosuppressive. Downregulation of acute protein production is also not any effect of cyclophosphamide on acute phase response would be considered secondary to the effect of cyclophosphamide on lymphocyte function. And then these are other is inhibition of neutrophil migration, and which is a number of agents which include matrix metalloproteinase inhibitor and which are used in inhibition of neutrophil migration, but cyclophosphamide hasn't got that mechanism. VEGFR is not the mechanism of cyclophosphamide, which we use in diabetic retinopathy and solid tumor, and but the cyclophosphamide hasn't got that effect. Then a 45 years old woman present to the dermatology clinic for review. She complains of increased facial flushing, which is becoming more permanent, mainly affecting her cheeks and the area around her nose. She drinks glasses of wine per week, 10 glasses of wines per week, but otherwise has no significant past medical history. Examination reveals erythema affecting both cheeks and nasolabial folds with small pustules around the nose. In contrast to the acne, the skin appears dry rather than greasy. Which of the following is the most appropriate initial intervention? Is it oral ibuprofen, minoxidil, 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 topical metronidazole. So always try to think that whenever such type of scenarios are coming, what state of the disease patient is on and how we have to escalate. Are we on the state that we have to give the uh, highest potency medication with having their side effects, or we have to choose something which is the primary and escalate it gradually until we get the response? Or sometimes the patients are coming with the severity that we have to start the final medication as the first or maybe the second line. Okay, so this is a scenario like that. Are we going for oral retinoin, for which we know it's highly teratogenic? We always say double protection of contraception we need to give. Are we going to give oral oxytetracycline? Have we ever tried the other topical medications or not? Is it pulse light therapy? Is it now the patient has got the complication of the disease which looks like acne rosacea here, and now we are, or the disease has been gone with leaving the trauma, leaving the damage? Are we going with the topical brimonidine, or we are going with the topical metronidazole? Yes, Maha, do you have any clue, or we should go with the explanation and answer?
Go with explanation.
So this is metronidazole. As I said, the topical metronidazole, which is an initial intervention for rosacea, which is a likely diagnosis. Dry skin with intermittent becoming more permanent. Facial flushing coupled with pustulant rash around the nose is a typical diagnosis, which occurs more commonly in the woman than a man, and is more prevalent in middle age. Oral isotretinoin, or they are used for rosacea, but who are resistant to other intervention, including topical and oral antibiotics, then they are, you will say, third line. On one trial compared oral isotretinoin with doxycycline for pustular rosacea, showed a great improvement in flushing, nasal pustule, and swelling of the patient satisfactory than antibiotics alone. But these are not the first line of treatment. Oral doxycycline, they are considered in the patient again after the topical intervention, as we said. If they are not working, then we can go for antibiotic and then isotretinoin. Pulse light therapy has benefit in managing the telangiectasis. Neither a laser nor pulse light therapy are strongly supported by Cochrane review. Brimodone is an alpha-2 agonist which is used as a topical therapy and can reduce the facial flushing, but it is less effective with respect to the resolution of nasal pustule than other intervention. So I would say, because there are not much candidates, so we will try, because we have to upload this one in our group. So we will complete the session now, and then we will try to upload this one in our all Telegram and Facebook group. And this is what, how we do our fast track preparation, how we explain the questions and scenario you have seen, just for the understanding of the students who like or want to come into the fast track group. We have made this 20 MCQ slide and we have explained them. Thank you, Maha, for attending this session, and we will complete this session now for ease of uploading this one in our Facebook and Telegram group. If you want to join our fast track, we have started it. It's still ongoing. Still, we have 1 month for Mrcp UK student and 1.5 month for Mrcp Ireland. You can contact us on our Facebook, Telegram, WhatsApp group. On any number, we will contact you and you can join us. Thank you very much, and we will see you other sessions. And if you are happy, join fast track. I will be there to help. Bye for now.